Okay, sorry for the technical issues. What we wanted to do is switch back and forth between the slides and the ventilator, but that seems not to be possible at this moment. And it's not really helpful if we show the slides here and the ventilator screen over there, right? Because other people won't be able to see. So what we will do is we first start with the slides and see after that if we have time to go to some ventilator screens. Depending on the number of questions and the discussion, if that's okay with you. And otherwise, I'm sure that the people from McKay are kind enough to stay just outside the booth, and we can do a short demonstration over there for the people who are really interested. I'm really sorry for this, but this is the way it is. Yeah, but I think people over there and there won't be able to see both screens. Okay. Katerina, do you want to introduce yourself first? Okay. So welcome everyone. I am Leo Heunks, a pulmonologist intensivist from Rotterdam in the Netherlands. Katerina Vaporidi.
Hi, I'm Katerina Vaporidi. I'm from the University of Crete in Greece. And thank you all for being here. And we are going to discuss about asynchronies on mechanical ventilation. Can I start by asking what is the mode of assist you use mostly? Pressure support? Assist volume? Not that much. Proportional modes? Few people? Okay.
We can do better.
Are we gonna? Okay. Are we gonna have the slides here?
So the technical team did a perfect job. So we have and both the slides and the ventilator screen. And now it would be perfect if I can advance the slide. Yes. So. Okay, this is what we want to do. We're going to discuss a couple of patient-ventilator asynchronies. Please ask questions. Also, there's a lot of discussion in the literature about this topic, so if you do not agree with us, which is highly likely, just raise your voice. It's perfect. I think that's a nice thing. This is different, at least should be different from just the presentations we have over there. Try to have as much interaction as you wish. So these are the different categories of patient-ventilator interaction, asynchronies. So it's the time asynchronies, flow asynchronies, entrainments, and there are some novel asynchronies that we would like to discuss if time limits. So let's start right here. For those not familiar with this screen, we're now looking at the slides, right? Not at the ventilator screen, so the slides. The upper trace is the airway pressure, flow, volume, and the electrical activity of the diaphragm. So is this like a perfect synchrony, or is there a problem here? Excuse me? We have at least two problems. Okay. So what are the problems? Maybe you can. You want to take the? I think COVID is over, so you can take the microphone. Could you imagine that it is
First, in the end-on-inspiratory pressure support, you have a peak. It's indicated too early expiratory. No, in a pressure support, you have a...
We're discussing this screen.
I'm
sorry, we're not discussing the ventilator screen, we're discussing slides.
Here.
Air trapping.
Focus on this breath. Pressure support.
You have air trapping. First, and sometimes you have a too long inspiratory time.
Have this electrical activity of the diaphragm. Microphone, okay? So the first thing we have right here is inspiratory delay, right? The inspiration of the patient starts at the beginning of the red box, but the ventilator cycles on at the end of the right box. So there is a delay. Is this clear for everyone? And secondly, as you already correctly identified, there's a cycle off delay. We would expect the ventilator to cycle off at around 80% of the maximum electrical activity of the diaphragm, but there is delayed cycle off right here. And I think the delayed cycle off, perhaps you could have identified it, but the late cycling is really hard to identify if you don't have any esophageal balloon or you don't have this electrical activity, right? So what is this? So right here you have, well, you can see flow and airway pressure. Anyone else? Wasted effort. So why is this a wasted effort?
You see in the pressure curve, you see, and also in the, is that flow? In flow you see a hub.
This one?
Yeah, so there's a little bit increase in flow, there's a little bit decrease in pressure, but nothing happens on the ventilator, right? And of course, it's much easier to identify if you have this electrical activity of the diaphragm. So that's the second asynchrony. So because late cycling and ineffective triggering is more like in the same category, right? The patient has difficulty triggering the ventilator, but with late triggering, he just can do it, but a little bit late in an effective trigger, there's no triggering at all. So what are the most important risk factors? Sorry? Oh, okay. Trigger sensitivity, sure. But I think that should be hardly a problem with all the modern ventilators, right? So second, more important probably, autopip, that's very important. Anything else? So muscle weakness or low drive due to sedation. So these are the three things you have to consider when a patient has this kind of patterns. So want to take over for now?
Sure. So what do you think, when you have an effective effort, you have actually an effort that is not strong enough to trigger the ventilator. That means it is not strong at all or not enough. And enough means, if we can have the next slide. Yes, because you're going to show it nicely. Intrinsic PEEP. What intrinsic PEEP is when the patient has an increased expiratory resistance, not able to exhale the volume you have has inspired. So the pressure the patient needs to develop to trigger the ventilator is not just what you require for flow trigger, but all the intrinsic PEEP and a little bit more to trigger the ventilator. So if we can advance them. And that happens obviously in the patient with obstructive lung disease. And we can adjust it either by adding some external PEEP, but also by reducing the level of assist. Because if we give the patient a high tidal volume, then he or she is not able to have time to exhale this high tidal volume. So decreasing assist is the first step we can take to manage a patient with ineffective efforts. The other cause of ineffective effort, if it's not intrinsic PEEP, it's weak effort. An effort can be actually weak because the patient has weak muscles, but very commonly because the patient has low drive. And the patient has low drive if we give them adequate assist to decrease their CO2 to the desired level, then they don't have to work. So they're not trying really. So if you decrease the level of assist, the patient will, briefly, have a higher CO2, which is what the brain needs to be stimulated to try and breathe. And another solution, if you have the patient very sedated, you may obviously need to decrease sedation. And also remember that metabolic alkalosis, which happens often when we de-resuscitate the patient, is a cause of low drive. If the patient has a pH of 7.47, for example, he's not really motivated to breathe. So you need to correct that. You do not need an EMG or an esophageal balloon to identify the ineffective efforts. Just focus on the flow and the airway pressure. Also, an important aspect to see when you are looking for ineffective efforts is that our breathing is pretty much rhythmic. So we have a constant, relatively constant inspiratory time. So notice here, one breath, another breath, another breath. I will show you on the next slide, the next type of asynchrony, because it may look similar, and this is how you can discriminate ineffective efforts from premature cycling off. So that's the steps we take. Triggering sensitivity is usually not your problem. Modern ventilators are, you can have that. Reduce intrinsic PEEP, that's medication. Increase extrinsic PEEP if you have an obstructive disease. Reduce ventilation, mainly reduce assist, but also you can decrease the cycling off, so the ventilator cycles off earlier. And if you have sedation, if you have metabolic alkalosis, you can correct that. Okay, so we can move on to a next asynchrony.
So you've discussed this, right? So go ahead.
Okay, so this is the opposite of ineffective effort. This is when what do you see? Clearly see? Yes, it's clearly a double triggering. We don't have the muscle pressure, and we don't need anything else to identify that the patient here, if we have
So can you just 1 second, so everybody could hear it. So this was double triggering. So what's the definition of double triggering?
That the patient is in the breathing cycles taking another breath.
Yes,
Okay, so
exactly.
that's important. So the patient triggers the ventilator twice in a single effort. That's double triggering, right? Thank you.
So you have a nice slide after that showing, yes. So here you can see the effort shown with the esophageal catheter. A really prolonged effort is able to trigger the ventilator. Here the expiratory valve opens, because when we have a pressure support mode, we set the time the exhalation valve opens as a % of peak flow. So if the patient has very poor mechanics, flow decreases rapidly and reaches this point that we have selected very early on. And maybe the patient is trying a lot. Usually, if they have poor mechanics, they may have also high drive. So they have really long and strong efforts, and they are able to trigger the ventilator twice. So high drive, short ventilator inspiratory time, low assist or low tidal volume, and low respiratory system compliance. This is the context where this asynchrony happens. So when we want to correct it, it's important to maintain, in order to maintain safe ventilation, not only to target inspiratory time or just increase assist. We should manage the conditions of high drive, especially if the patient has a very low compliance. Otherwise, we will end up with a patient taking a very, very high tidal volume and having high lung stress. Okay?
So maybe we need to discuss how we're going to solve this problem?
Yes. So on the ventilator, you have this option of choosing in pressure support the cycling off criteria that defines the % of peak flow that the ventilator will cycle off. So the first step you would take, if you see this, is go to a lower, allow the flow to go to 10, 5%, and see if this solves the problem. But always keeping in mind that if the patient is trying too hard, they may feel distressed, they may have very high tidal volume, and this type of asynchrony may be also a marker, not a problem that you solve just by managing the ventilator cycling off. Okay? Like to add something? So, if it's not that extreme, double triggering, we may have the same problem but to a lower extent when we have early cycling off. So the ventilator opens the exhalation valve before the patient effort is finished, but this effort is not strong enough to trigger a next breath. What you can see is this type, the patient is still inhaling, so after the opening of the exhalation valve, the flow, instead of becoming expiratory, tends to go towards inspiratory, but that doesn't fully reach the level of triggering. It doesn't become inspiratory. And you see the pressure in pressure support mode rising again. So this is actually the same problem, but not to the same extent. The effort is longer than the neural time is longer than the mechanical one. And what you need to do is increase the mechanical inspiratory time. So again, the first step is to decrease the cycling off criteria. Here it's much easier and safer to solve the problem just by managing the cycling off criteria.
Okay, next asynchrony. So what's going on right here? Anyone an idea? Or is it just perfect? Probably not, right? Yeah, exactly. So this is probably auto-triggering, right? And it's, again, easier to identify with the EMG, but you'll see there's no patient effort, but the ventilator is triggered anyways. And we'll speed up a little bit. And you'll see that if the trigger sensitivity is too sensitive, I mean, patient, just cardiac activity, changes in interthoracic pressure due to cardiac activity could trigger the ventilator, right? Movement of fluids in tubing could trigger the ventilator and could result in hyperventilation.
Just one quick point here. You may have auto-triggering by hiccups. This is the most difficult. You cannot solve that by managing the ventilator because the hiccups cause a very large decrease in esophageal pressure and intrathoracic pressure, so there's no way you can discharge this triggering. You have to solve the problem of the hiccups.
Yeah, that's a very important point, right? I'm not sure if it's in the definition of auto-triggering, but sometimes what people do is change trigger sensitivity, and I think that's the last thing you should do, right? I mean, as you can say, you cannot solve hiccups with changing ventilator settings. It doesn't make sense, because if you set the ventilator very insensitive, it will be very hard for the patient to trigger the neck breaths, right? So this, what do we see right here?
We've changed mode. Notice, so it's assist volume now.
Yeah, people are discussing it right here. Yes, so it's a flow asynchrony, flow starvation. As you can see, right here, the dotted line would be if there's no patient effort. I think this is more or less acceptable. But right here, it's what's said, the patient is outsucking the ventilator, right? If you see these kind of patterns, you're providing too little flow. I think that the most important part here is for all the asynchronies, and I think that's a nice thing about mechanical ventilation, just review your ventilator screen every time you're doing the rounds. There's so much you can learn from that. Okay. So we have a quick case to discuss right here. It's a male, 35 years of age, no past medical history, admitted to the ER for cough, dyspnea, fever, bilateral consolidations, PF ratio 130. And the problem is he is fighting the ventilator. And this is how it looks like. So the upper trace right here is pressure, flow, and volume. And as you can see, he's in volume-controlled ventilation. Tidal volume 450 ml, respiratory rate 24, PEEP of 12. So if you look just right here, what would you say? Reverse trigger. So how would you recognize reverse trigger right here? So she says no patient effort, and then there is a patient effort. Does everyone agree? I don't. I don't think you can say here that this is reverse triggering. Why not? Someone agrees with me? Because why is this not just by coincidence that the patient is just taking a breath? Okay, but I think you were right.
You cannot tell.
No,
This really is the way to tell.
But right here, let's start the video. Can you start the video, please? Oh. Ah, there it is. There it was. Can you start it again, please? So move one back. And can you now start the video? Okay. So what you'll see right here, so this is a mandatory breath, another breath, mandatory breath. There it is. So this is very important. With reverse triggering, there should be a pattern. So you can never say it on one screen, and it could be 1-1, it could be 1 and 2. In this case, it's 1 and 3. But it's very important for you to have a diagnosis of reverse triggering, that there is a pattern. And it's easier to identify right here. It's the same patient a little bit later on. So we had a 1 in 3 pattern. Now it's 1 in every 2 breaths, as you can see here. Well, it makes it a little bit easier again. Okay. I'll show you in a second, right here, with the esophageal balloon. Right here, pressure, flow, volume, esophageal pressure, and the transpulmonary pressure. So right here, this is a mandatory breath. There's a rise in esophageal pressure, as you would expect with mandatory ventilation, right?
Okay, so here, patient triggers the ventilator here. Okay.
So right here, starts with ventilator triggering, and after that, the patient is triggered. So it's not the patient triggering the ventilator, but the ventilator is triggering the patient in a very specific pattern. Is this a problem? Do we worry or do we don't? Yes, why? Yes, it may result in very high tidal volume. Not necessarily, but it may, right? So in this case, as you can see, right here there's an inspiration and expiration. And this is the inspiratory volume, the area under the curve right here, right? But in this patient, there's an inspiration, hardly any expiration, and there's a next inspiration. So tidal volumes are actually doubled. So this could be problematic. So again, so the characteristics of reverse triggering, it's a stable and a repetitive pattern. There's minimal, really minimal variation in pattern. It's, if you look at it, it's in a few milliseconds, always the same between ventilator triggering and patient triggering. And it's more likely with higher levels of sedation. So you do not have, of course, reverse triggering in patients on pressure support ventilation. You just skip this for a second. So your diagnosis is quite easy. You just do an end expiratory occlusion and it should completely vanish because there's no ventilator activity, so there's no reverse triggering here. Well, possible harm already identified by you. So does anyone know why do we have reverse triggering at all? I mean, from an evolutionary perspective, I mean, we were not made for being on a ventilator, right? So is there any reason for reverse triggering? Anyone has an idea? So why would there be a reason to synchronize your ventilation with external stimuli? Because that's what's happening, right? You're inflating the lung and you're activating your brain centers. I think this is one of the, I think, most intriguing papers I read in the last years. And it was already published in the 50s in Science. And one of the possible reasons is, you know, at the time that we were still running out there in the desert, and we were still running on 4 feet, it was very important to synchronize your breathing with your running pace. So that's probably the reason. There is receptors in the lung, but there's receptors in your arms and legs as well that provide inputs to your respiratory centers to synchronize breathing with external stimuli. I think this paper is really fantastic if you want to read it. Really fantastic. So they studied it in horse and in humans as well.
And
okay, you take over.
There are also experiments in healthy volunteers, in any of us, if we are asleep and you put us on the ventilator, you can find this fine level of tuning that we can have reverse triggering. So we can all synchronize with an external stimuli. This is important. The maneuver, either expiratory hold or place the patient on CPAP briefly, it's important to discriminate because the more you sedate the patient, the more likely reverse triggering will occur. So if it's a patient effort, though, and it may be because you may have a very stable part, and the patient may be heavily sedated, ventilated with 30 breaths per minute, and have a breathing pattern on his own of 15 breaths per minute. So that you see 1 every 2 breaths and you think it's stable. And then you press CPAP or an expiratory, and this continues. If the patient has an effort, you can sedate them. If the patient does not have an effort, it's reverse triggering. You have to either paralyze or awaken them. You may play with the timing. People, because it happens that people get locked in a specific time. If you modify a little bit the timing of the breath, change the respiratory rate by 1 or 2, the phenomenon may disappear, and it's worth trying. So we're running out of time, so we have one more. And if nothing else works, neuromuscular blockers. Okay.
So I don't think we have the time for the second case. Is there something you want to show on the ventilator right now?
I think, yeah, we need to...
We have like a few, we started 10 minutes late, right? So if
Okay. So can you show us the next period? So the curvature of the inspiratory flow during pressure support can help us identify the end of neural inspiration. When it's curved, like that one, the patient is contributing to the effort. When it's, can you make a quicker effort for me? When it becomes linear, or even if you see a scooping like that, an exponential decay, this is passive ventilation. The patient has relaxed their muscles at that time point. Maybe we can see that. I don't think we can. Yes.
So in the meantime, is there any other question or concern you want to raise? Or anything you don't understand in the patient-ventilator interaction that you would like us to discuss?
How to solve the double triggering in the ventilator?
In the ventilator. Okay.
Can you repeat the question, Katerina?
So the question is how to solve the double triggering on the ventilator. So in pressure support, we manage inspiratory time by 3 things, because inspiratory time depends on peak flow, which again depends on patient effort, that's not in our hands, on the level of assist we provide, that's in our hands, and the cycling off criterion. It also depends on mechanics, but that's also not in our hands. So what we have in our hands is the level of assist and the cycling off criterion. If we want to prolong inspiratory time, we can increase the level of assist and decrease the cycling off criterion, which in this ventilator here is here, the percent of end inspiration, and this is a characteristic. So I'm going to, and see how it moves towards the beginning or the end of the peak flow. It's important, once we identify such a synchrony, it's important to solve it, obviously, but you need to remember also that the patient doesn't have a very stable inspiratory time when it's in pressure support. I mean, you can fix it now, but that doesn't mean that if you never see the patient again throughout the night, the next morning everything will be fine. We have a natural breathing variability when we are in assisted mode, and that is, it can create a problem sometimes. But our tools to solve it is these 2. Increase the level of assist if appropriate, or increase inspiratory time by decreasing the cycling off criterion. Okay, first the first move is cycling off criterion and then increase assist.
Okay, I think, please, one question.
Do you think IntelliSync in the ETS or cycle off time is a solution for that? the IntelliSync in the cycle off time. Is that a solution for that? We use Hamilton ASV.
Which one?
We use the Hamilton ASV, and it has an IntelliSync on it on the ETS time, so it adjusts itself.
I don't have.
I think.
I don't have
Which
experience
one?
with the Hamilton, to be honest.
The Hamilton.
Okay. Then we have to look at it.
So the Hamilton has taken this flow shape. Actually, they use this principle of operation that the flow shape changes once the ventilator, the patient effort is no longer present, and they adjust the expiratory time with that. So it actually does what you can do by eye, but it does it automatically, and that should solve the problems in a more kind of stable way when you're not looking.
Okay, I'm afraid we have to close this session. Thank you very much, Katerina. I would like to thank the people from Mackay for supporting this, and enjoy the conference.